This topic is near and dear. We were just, Dr. Rossoff was mentioning, just talking about the importance of this issue for all of us, and in particular for coming from my background. I come from a pure immigrant background. My mom came through Ellis Island, not speak a word of English, from Hungary. My grandparents came through to this country from Lithuania, and so grew up in a three-language family that actually had to learn its way in a lot of ways, and always sustained their culture and their language, while at the same time acculturating to this world, and have literacy, language, and culture were much a part of what we face. So it also added a gift to me is the richness of that background. So what I'd like to do today, it's certainly born in part from that background, is kind of reiterate a little bit what Dr. Rossoff was speaking about, because it also binds what will follow regarding the Affordable Care Act and related transformational issues in the healthcare world these days. So when I was thinking of putting this presentation together, I thought, well, what are the new emerging issues? Some of them continuity. Some of them are really kind of now at a stage where we're seeing kind of a more assertive aspect of how these different issues, dynamics, actions, energies are affecting healthcare decision-making and health policies. New financing and program incentives, and Dr. Rossoff did mention a number of these, but I think it's worthwhile for the sake of kind of binding what follows, bringing these up. New pressures and requirements around health contracts, health insurance, heightened competition now. There's contraction in the field that's different from the way it was years ago. Demographics and certainly overall newly insured, creating new opportunities to draw in new populations, and movement to population health, social determinants of health getting more and more resonance, community health needs assessments coming up. These are elements both within and beyond the Affordable Care Act. So this kind of sets a context that both brings on the greater complexity that Dr. Rossoff mentioned, but the greater opportunity that a lot of healthcare systems, healthcare settings are seeing and trying to position themselves to take advantage of. And much of this work also, or the thought behind this list, comes from work that we've been doing in a number of quarters to look at the implementation of the Act, how it's unfolding, how are organizations in the field seeing opportunity or being concerned about their future existence, existential issues that are actually coming up, certainly among a number of these organizations. How can I live in this new world? So opportunities for healthcare reform in the era of healthcare reform. Certainly, the ACA has created a number of opportunities that we now see and have been tracking for basically since it was born. Health insurance, health systems transformation, healthcare workforce issues, disparities, data and research, and public health and prevention will be the areas that I will touch on now. And with health insurance, I bring up health insurance. I know the focus and much of what we're talking about today is on patient care and service systems and healthcare generally. I think there's some really interesting examples that are coming through health insurance marketplaces, especially in the leading states that have both are thought-provoking and are lessons learned for broader issues around literacy, language, and culture. There are requirements in the law around benefit summaries and claims appeal processing and plain language, other priorities around literacy, language, and culture that marketplaces, new entities were required to address and to report on. And so, and whose feet are held to the fire around these issues. So the navigator programs, the assister programs that are put together, other programs have required people in training not to just have a language capacity or a language facility, but literacy and culture have merged in these settings where you're dealing with somebody on a phone or in person, and they may be challenged in a number of these ways, and the person sitting there as an enroller sister can't say, you know, I know literacy, but I don't know culture. You know, I've got to do something. I've got to call in somebody else to do that. Or I know language, not so much on literacy. So these folks have had to be kind of a be-all in a lot of ways, or have reference points within their settings to address this. We've done work on looking at enrollers, assisters, and have documented some of these efforts in some of the leading states in the country. For healthcare systems, the medical home initiative, some of these we've actually addressed before, and these are kind of continuity. These are kind of points to monitor as they develop, initiatives to monitor as they mature or as they progress. And I think they offer opportunities for organizations to say, literacy, language, and culture must be part of these efforts. So we have within the medical health home initiative areas, we have initiatives. We have communicating in a culturally appropriate manner, culturally appropriate family support for medication adherence, health literacy, patient health assessment, accounting for culture, language, and literacy, and use of evidence-based, culturally sensitive wellness and prevention programs. So by their nature, these efforts need to find a way to find a synergy, a point of focus where these three priorities are brought together. You know, again, the efficacy of keeping these distinct and separate and saying I can't do one, I can only do the other, just it's not going to work. So there are these incentives that if I'm going to be good at what I'm doing here in developing health homes, for example, then these are initiatives that we need to undertake. There are some examples. Iowa, New York, and Ohio require that individual and family support services be provided in a culturally appropriate manner to assist with medication adherence, health literacy, addressing physical, social environment of the patient, et cetera, et cetera. These and others, I won't go into detail because of the lack of time, but there are a number of existing initiatives that are moving in this direction. Accountable care organizations are another example and an opportunity where these three priorities will need to be and are encouraged to come together, lest you continue to have this fractionation and failure to really address the needs of patients. And workforce. Again, these are provision-related examples within the law that I feel really represent the opportunities for pursuing an integrated approach. Building training competencies is part of the law. The Affordable Care Act recognized there was a whole list of provisions related to training and education. When we looked at the law, there were 62 provisions related to disparities, equity, race, ethnicity, language, culture, literacy, and so it has rich potential, and what has been manifest has worked out really well. The question is, when you get down in the law, the intent was never fulfilled. So what ended up happening was Congress basically, well, I was going to add an adjective in there, but I'll beg off the adjective, and blank wisdom, really decided, we don't want to fund these programs. So there were a number of somewhat visionary efforts within the law to move it further in ways that could facilitate this integration, such as primary care training and loan repayment programs, a preference for cultural and linguistic competence and health literacy experience, team-based care, support for community health workers in their role in helping LEP, low, literate, and other diverse patients navigate the system. These are provisions that were not either fully or funded at all. But it shows what could be done, and actually we've talked before, a number of groups say if you want to advocate for areas within the law that are already authorized, then these are some of the points that might be considered for further action on your part. On data and research, standards for collecting race, ethnicity, language data are embedded in the law and have been kind of moving along slowly, but as we know, there is a certain, when it comes to data with regard to, again, appropriation, it's kind of like a see no evil, hear no evil, speak no evil. See no data, hear no data, don't worry about the data, because we'll make sure that it's not there. So there is not much support for documentation, which in this world of literacy, language, and culture, and the integration thereof, is critical. But the support generally is not there, and specifically for furthering and maturing this development of data is a challenge. There is obviously some progress, but not nearly as much as what we would like to see. PCORI, Patient-Centered Outcomes Research Institute, does offer, again, opportunities through intervention addressing patient characteristics, strategies to overcome cultural and linguistic barriers, and health communication models to improve outcomes among patients with low literacy and numeracy. These are examples of some of the areas that PCORI has tried to focus on, again, offering that window of opportunity. And public health and prevention. For federal focus on health equity with new agencies generally at that policy level at least create these places where such attention could focus. And then within the public health and prevention provisions, the National Prevention Strategy has one of its foci on eliminating health disparities, where it has introduced a study of health literacy factors in patient safety and increasing use and sharing of evidence-based health literacy practices, plain language patient information, labeling tailored to cultural language and literacy, and real data collection. So, if you look back 10 years ago, were parts of these floating around? Yes. Were they now becoming more concerted, more energized, more at least supported in some ways, and more relevant in terms of the field? I think there has been a significant step forward in that sense. So what's ahead in terms of points for consideration? Framing this integration in the context of system priorities. We have population health now, which has now become more and more relevant to the field, and more and more attention being paid. The issue about population health, I'll tell you though, has a sidebar. They're an important sidebar to recognize. As we've done work looking at safety net transformation, what we've found is that many folks who are trying to move to population health, the world of reimbursement is lagging. So they've got themselves in a bind, what somebody called literally a two-canoe situation. What they said is, on one hand, we're trying to move to social determinants and to address population health issues, work more with community-based programs and prevention. Where's reimbursement come from? I've had one of my stories that brought this home very directly to me was talking to a doc who was at that time a leader in a foundation in California, and I said to him, this energy to move to prevention is embedded in the law, and I think it's something that could be breakthrough. And he said, well, let me tell you what I'm doing tomorrow. I'm going north to speak to a bunch of docs at a hospital about spinal surgery. That's what they're interested in. So I said to him, yeah, but what about folks with diabetes, where you want to keep them out of the hospital? He just thought for a second, he just said, amputations, that's what they're interested in. Prevention, not so much. That's not where the money is. So you've got this disconnect. We talked with one model system, what I would call a good model system that's been around for years. And the person there said, we're kind of screwed. You know, we've been trying to push toward population health, but where's the money coming from? So, and until now, there is hope in some ways around some of the requirements that come around readmission and other aspects that are very much related to literacy, language, and culture. And to that extent, these are opportunities that need to be grabbed by the field, and you say, okay, look, these are your requirements. These are the business of health issues where literacy, language, and culture can really, not only can help, but must be considered if you're to avoid some of the consequences of not paying attention to these other issues. My friend, I'll just move you over here before I knock you again. Value-based care, again, looking at values and the way in which the dollars are going to follow the quality in this new world. So basically, tying dollars to integration of literacy, language, and culture is one other way in which it's a door that could open that could provide opportunity. And I mentioned patient safety and around readmissions and hospital-acquired infections as ways in which, from a business perspective, could have resonance. Drawing lessons learned from the marketplace, as I mentioned, because I really feel that it's worthwhile looking to. There are people who are now experienced in all three areas that are emerging and are positioned within marketplaces like California and Connecticut, in particular, and some of the other leading marketplaces. And that could have relevance to services, but obviously could have relevance to other marketplaces. I will also mention this briefly, that there are the waiver programs as opportunities that are arising that provide different kinds of ways in which literacy, language, and culture is already emerging as important, or are, again, ways to get the door further open. You have use of CAPS, Consumer Assessment Health Plans, survey to measure patient perceptions of physician-patient communication. Both Texas and California are applying that in their waiver programs. Implementation of class standards, of course, we can't, I would be remiss to end my presentation without mentioning the role of class, because class is one of the training aspects of the navigators and assisters. They have to go through class training. So that's another opportunity. In Texas, they're looking at the implementation of class standards, including those not fairly required. Workforce cultural competence trainings, engagement of community health workers in evidence-based programs to increase health literacy, patient care navigation for LEP, immigrant and low literacy populations, and redesign of patient materials reviewed for health literacy and by health literacy experts and language experts. So these are these waivers offer, if you get into them at all, there are nuggets in here that are of value too. Building an evidence base, data. Somewhere along the way, I know when we were talking about this meeting, I kept on saying, if you can't document, look at what's happening and look at the effect and then look at what works and what doesn't work, then you're constantly going to be seeking information partly in the dark. So the idea of finding a data set that can, or a way data-wise to integrate these and then analyze the results is really important. Need to build an evidence-based linking language, literacy, and cultural competence, needing to monitor health equity outcomes to assure equities are not an adverse outcome of related initiatives. All are part and parcel of moving ahead. I'll close with this scenario because I think this is what we want to find is that you are actually in the middle. You're actually lowering disparities for all while there is a convergence at a lower level. What we want to avoid with our different efforts here is the first and the third, where there's really no change in the third and the first, even though there's improvement, which you have happening. And I think without attention to literacy, language, and culture, you will have one or the other, and you won't have the middle. And so literacy, language, and culture are critical to any system-level advance. That is clear. Without its integration, and in drawing really from the workshop of IOM before, it's a sense that there are many lessons from the workshop, from Winston's work there and others in the initial workshop that really ground this workshop, I feel. But the conclusion in part reached that it'll be half empty if you do not address this, and I think resonates and is an important lesson to learn as we move ahead for the day. Thank you.